Welcome to the Deep Dive. Today we're plunging into a bit of a medical mystery, pulled straight from the Journal of Orthopaedic Case Reports. We're looking at a condition called chronic recurrent multifocal osteomyelitis, CRMO for short. Quite a name, but understanding it is, well, pretty fascinating. Our mission really is to take one specific case report about a 13-year-old boy and use his story like a magnifying glass. We want to understand the challenges doctors face diagnosing and managing this rare inflammatory bone disease. If you've ever wondered about that whole diagnostic process, the detective work involved, especially for things that aren't obvious at first, you're in the right place. So let's unpack this. Chronic recurrent multifocal osteomyelitis. Sounds complex. What does it actually mean for the kids affected?
Right. So at its heart, CRMO is a chronic inflammatory bone disease, primarily affects children, adolescents, and crucially, it's non-infectious. So no bacteria, no virus causing it. It's also termed benign and self-limiting, which sounds good, right? Means it's not typically life-threatening, might eventually resolve. But the catch is that recurrent multifocal bit. It means patients get these repeated bouts of inflammation, and in multiple bone locations, it causes these, well, lesions. Some break down bone osteolytic and some harden it sclerotic. So while it is technically self-limiting, its recurring nature makes it a real long-term challenge.
That's a key point. Not an infection, but it causes similar issues, like the body's attacking its own bones by mistake.
Exactly. It's a sterile inflammation. And yes, location matters. These lesions can pop up in the metaphysis of long bones, where the shaft meets the end in arms and legs. Also pretty common in the spine, pelvis, even the jaw. But here's a really important clue, kind of hallmark sign: the clavicle, the collarbone, especially the medial end, closer to the chest center. That's often a big red flag for CRMO.
Okay, the clavicle. Got it. So what would a child or maybe their parents actually notice? What sends them to the doctor?
Well, the symptoms can easily mimic other more common things. That's part of the problem. They might complain about pain in several joints, kind of comes and goes, maybe some swelling, redness locally, sometimes even a fever. And to make it even trickier, CRMO can link up with other inflammatory conditions.
Oh, really? Like what?
Yeah, it gives you a hint about its systemic nature.
Right.
About 8% of cases have this skin thing, palmoplantar pustulosis. Around 10% might also have inflammatory bowel disease like Crohn's or colitis, and another 10% could have severe acne. It suggests a broader underlying inflammatory tendency.
Wow, okay. So this is where it gets really tricky then. If the symptoms are so varied and they overlap with other conditions, why is it so often missed or diagnosed late? It sounds like diagnostically it's a real tightrope walk.
That's exactly it. It brings us to a crucial point. CRMO is usually what we'll call a diagnosis of exclusion. Think of it like this.
Right.
There isn't one single test that lights up and says CRMO. Instead, doctors have to carefully, systematically rule out everything else it could be.
Right, process of elimination.
Precisely. Because there's just a lack of really specific clinical signs, no definitive lab test, and routine x-rays. Often they look completely normal, especially early on. That can be incredibly misleading, frustrating for everyone involved.
That makes total sense.
Yeah.
So if x-rays aren't always helpful and there's no magic blood test, what do doctors look for? What investigations are involved in this sometimes long journey?
Well, they cast a pretty wide net initially, trying to rule things out. They'll run a full blood count, check inflammation markers like ESR and CRP, that's erythrocyte sedimentation rate, and C-reactive protein. They'll also look for markers of other autoimmune conditions, rheumatoid factor, anti-nuclear antibody, HLA-B27. But, and this is key, these often come back normal, or maybe just mildly elevated, like we'll see in the case study. And absolutely critical, blood cultures will always be negative. No bacterial growth. That's vital for ruling out standard osteomyelitis caused by infection.
Okay, so ruling out infection is paramount.
Yes. And then the real game changer for imaging, often where things start clicking into place, is the MRI, magnetic resonance imaging.
Oh, okay.
An MRI is really good at showing marrow edema, basically swelling inside the bone marrow, and it often shows this in multiple spots. For active disease, particularly in that telltale clavicle, it can show bone destruction in the inner part, often with a kind of layered look on the bone's outer surface, the periosteum. Importantly, you don't see sequestra, those fragments of dead bone common in infection.
Right. And I saw the article mention specific diagnostic criteria too, like Janssen and Bristol criteria.
Yeah.
The fact that these checklists even exist really highlights how complex this is. It's definitely not straightforward.
Not at all. It takes a structured approach.
Okay, let's shift to the heart of this deep dive now. The case itself. A 13-year-old boy. He presented with, what, a 5-month history of this gradually worsening, dull, aching pain. Can you tell us more about his initial symptoms? What made his case tough?
Yeah, so his pain was mainly in both hips, but it also radiated, spread down his thighs, knees, even his ankles. What was interesting, and again made it tricky, was that medication helped the pain. He didn't have those general constitutional symptoms like weight loss or fevers. He was still managing his daily activities.
Okay.
And then when they examined him, completely normal physical exam, you can imagine the frustration for him and his family. Months of pain, seeing doctors, no clear answers yet.
Definitely. That sounds like it'd be so many things. Growing pains, muscle strains, anything, really. Were there any early clues, maybe in his family history?
There was one subtle but potentially important detail. His older sister has juvenile idiopathic oligoarthritis. Ah, another autoimmune condition.
Exactly. While it's not CRMO itself, that kind of family history can sometimes flag a potential genetic predisposition towards autoimmune or autoinflammatory issues. It's a small clue, but valuable if you're thinking broadly.
Okay, what about his lab tests? Did they give any clear answers, or were they just as confusing as the symptoms?
Mostly confusing, unfortunately. They really highlight the challenge here. His ESR, that inflammation marker, was a bit elevated, 46. So some inflammation, but not sky high.
Okay.
But his CRP, uric acid, TB test, HLA-B27, rheumatoid factor, all normal or negative. And crucially, like we discussed, his blood cultures, no growth, definitely ruled out an infection.
Right, so no bacterial cause found there.
Nope.
So the diagnostic puzzle continued, common causes ruled out, and his x-rays were normal too, which we know can happen with CRMO but doesn't help much early on. What finally broke the case open? What revealed the underlying problem? This is exactly where the MRI was absolutely indispensable. They did an MRI of his pelvis, hips, thighs, and also screened his clavicles. And it showed these altered signal intensities, basically, that marrow edema, the swelling inside the bone in multiple locations.
Multiple spots. Okay. Where exactly?
In both hip sockets, the pubic bones, the big iliac bone in the pelvis, also the right thigh bone, both shin bones, and, most tellingly, his clavicles, the collarbones, with the left one actually more affected than the right. This widespread pattern of marrow edema, especially hitting the clavicle, that was the breakthrough. Highly suggestive of CRMO.
Wow. It sounds like real detective work, piece by piece, ruling things out. Until this MRI pattern emerged, what else did they have to definitively exclude before settling on CRMO?
Exactly. They had to be absolutely sure, especially ruling out more serious things. So a bone marrow biopsy was done.
Okay, why was that necessary?
Primarily to exclude any kind of blood cancer, like leukemia, which can sometimes present with bone pain. Thankfully, the biopsy came back normal. Healthy bone marrow making all the blood cells properly, no abnormal blast cells.
That's a relief.
Huge relief. And as we already covered, the negative blood cultures ruled out infection. So they systematically checked off all the other major possibilities.
So after all that, ruling out everything else, how did they officially make the CRMO diagnosis for him?
It came down to a multidisciplinary team discussion. This is really key in complex cases. You had specialists from orthopedics, radiology, pediatric rheumatology, and even pediatric oncology involved.
A real team effort.
Absolutely. They looked at all the evidence together, the clinical picture, the labs, the crucial MRI findings, the negative biopsy and cultures, and the collective conclusion was that all the features pointed strongly towards CRMO. It just underscores how vital that kind of collaboration is for these rare, tricky conditions, especially in kids.
No doubt. And once they finally had the diagnosis, what was the treatment? And how did the boy do?
He was started on injections of pamidronate. That's a type of bisphosphonate medicine that helps with bone metabolism. He got 2 doses. Along with that, just supportive care, good pain relief, making sure his nutrition was optimized. And the good news is he responded really well.
Oh.
Yeah, his pain reduced significantly, clear improvement in his symptoms, much better quality of life for him. Now, if we kind of zoom out and connect this to the bigger picture, while this case turned out positively, it's important to remember the long-term nature of CRMO. Even though we call it self-limiting, it often has these cycles, right? Flares and periods of remission. It's chronic, needs ongoing attention.
Right, and you mentioned earlier the cause, the pathogenesis, isn't fully understood. Is something about an imbalance in cytokines?
Precisely. The exact why is still being researched. Cytokines are like the immune system's messengers. The thinking is there's an imbalance, maybe too many pro-inflammatory signals like IL-6 or TNF-alpha, and not enough anti-inflammatory ones like IL-10. This imbalance is thought to drive that abnormal bone inflammation and turnover, but the importance of getting the diagnosis right and early can't be overstated. Pamidronate worked here, but the bigger lesson is that an early, accurate diagnosis avoids unnecessary treatments, aggressive medications, maybe even surgery for suspected infection or cancer that isn't actually there. And again, that clavicle involvement, especially if it's not from an injury, that's a really strong clue. Infectious osteomyelitis rarely hits the clavicle, so it's quite specific for these inflammatory lesions.
That really brings us back to the core message, doesn't it? That diagnosing CRMO is this process of exclusion. It needs that comprehensive evaluation, the multidisciplinary discussion, to guide the right management, which is often conservative, and then that crucial long-term monitoring for potential complications.
Yeah.
But what are those potential complications if it's missed or not managed well over time? What's the long-term risk?
This is really critical. While many do well, some patients can end up with significant long-term issues, things like residual bone deformity, even muscle wasting or shortening of the affected limb.
Learning.
Yeah. For instance, one study found nearly 3/4 of patients had some leftover symptoms long-term. Almost half had recurrent pain. And a small percentage, about 2.5%, had actual bone deformity or mobility problems. Another study followed kids and found leg length differences in 5 out of 8 cases. One patient actually had a 5.5 centimeter shortening. That's over 2 inches. Needed a major leg lengthening surgery. So yeah, continuous follow-up right through until the child stops growing is absolutely essential. You need to watch for these things and intervene if needed. It's not just about the pain now, it's about their future function.
What an incredible deep dive into CRMO. Seriously, we've seen how this condition, easily mistaken for other things, needs such a dedicated, collaborative, almost detective-like effort. From spotting subtle clues in the history, using the right tools like MRI, to building that team approach for diagnosis and care, it's quite the journey.
It really is. And this whole journey, exploring a rare disease like CRMO, it kind of leaves us with a question for you, the listener. How might our understanding of these inflammatory processes, especially in rare conditions, keep evolving? How can we get even faster, more targeted, less invasive diagnoses in the future to really shorten that difficult diagnostic tightrope walk and improve those long-term outcomes for young patients? What might the next breakthrough look like?
Great question to ponder. Until next time, keep digging, keep learning, and keep asking those deep questions.